Hi, my name is Yuriy Kolesnichenko. I am a sonologist from Moscow, Russia, and today we talk about varicocele in the practice of pediatric sonography. Varicocele is a dilatation of plexus papilliformis veins which drains blood flow from the testicle and epididymis and formed a testicular vein. Varicocele occurs in 14 20% of healthy men and more often with infertility in 35–40%. Varicocele is rare in children under 10 years of age. Varicocele occurs more often on the left side and may be asymptomatic or may manifest as enlargement or mass lesion of the scrotum, pain in the scrotum. Varicocele can be primary or secondary. In most cases, it is primary on the background of the congenital absence of valves in the testicular vein, but it also can be secondary on the background of thrombosis, stenosis, compression of the left renal or testicular veins. The etiology of infertility in varicocele is considered to be overheating of the testicle by a network of varicose veins, which negatively affects spermatogenesis. Varicocele does not always require treatment. Treatment options for varicocele are varicocelectomy and papilliformis plexus varicose vein embolization. Varicocele is perfectly detected during physical examination, usually by surgeon or urologist, but there are also so-called subclinical form of varicocele. Those that are not diagnosed by physical examination, as well as unclear cases. For example, when varicocele is combined with hydrocele, which make physical assessment difficult, or when other diseases mimic varicocele, such as Sinner syndrome, in which the dilated vas deferens mimics the veins of papilliformis plexus. In such unclear cases, clinicians resort to instrumental diagnostics, which may include sonography, ultrasound, angiography, venography, CT, MRI, scintigraphy, thermography, and of course the most popular method is ultrasound. The criteria for varicocele by ultrasound is the visualization of veins and the scrotum, which more than 2 mm in diameter, in the standing position, and during the Valsalva test, the diameter of these veins usually become 3 or more millimeters, as well as registration of venous reflux in these veins in the spectral Doppler modes, PV pulsed wave Doppler, with the determination of reflux duration. Varicocele with reflux lasting more than 1 second is considered significant in increasing the risk of infertility, which is consistent with the method of F. Cornut et al. Method of F. Cornut et al. In particular is mentioned in the ultrasound handbook edited by Mitkov. Translated from Russian. According to F. Cornut et al., short reflux, which they define as physiological, lasts no more than 1 second. Intermediate reflux, characterized by a gradual decrease in blood flow velocity and ending before the end of the Valsalva test, lasts less than 2 seconds. And finally, constant prolonged reflux, characterized by the plateau curve shape and accordingly by constant blood flow rate and continuing during the entire phase of tension of the abdominal wall, lasts more than 2 seconds. I do not note the degree of varicocele by ultrasound, and in my opinion, the degree of varicocele is a clinical diagnosis made by a urologist. In particular, in this regard, I would like to cite one more quote from ultrasound handbook issued by Mitkov, translated from Russian. There are many domestic and foreign classification of the disease based on the severity of the dilatation of the papilliformis plexus veins and the violation of trophism of the testicle. The concept of staging today has rather historical character, since the correspondence between the degree of dilatation of venous vessels and impairment of the fertilizing ability of sperm has not been identified. However, not all urologists agree with this. Another quote from the first edition of Ultrasound Handbook of Mitkov, translated from Russian. There are 3 stages of varicose veins of spermatic cord. In the first stage, the dilatation of the venous vessel is determined by straining the patient or then examining him in a standing position. When examining in a horizontal position, the lumen of the dilated venous vessel decreases. In the second stage, the dilated venous vessels are determined at the level of the upper pole of the testis and slightly below. The dilatation of the veins of the spermatic cord remain during the examination in the supine position. In the third stage, varicose veins are determined below the lower pole of the testicle. There is a decrease in size of testicular atrophy. Here you can see classification of Sartehi. 5-stage. For example, you can read this in pause mode. Also, there are another classifications. In this slide, you can see a simplified, modified classification of Sartehi. Only 4-stage. You can read this at pause mode too. And another classification by Dubin et al. Also 4-stage, and this one is scoring system for varicocele by Chu et al. You can see that there are a lot of criteria, and overall score 4 is considered as varicocele. Method of performing ultrasound to the scrotum in case of suspected varicocele. The study is carried out with high frequency linear probes with a frequency of from 7 to 12 MHz. As in addition to the usual ultrasound of the scrotum, it is imperative to perform a polypositional scan, examination of patient in the standing position. Because in the supine position, varicocele may not be detected. A Valsalva test maneuver is also performed. The patient is asked to take a deep breath, hold his breath at the height of the inhalation without exhaling, and then strain his abdomen muscle. During the Valsalva test, blood flow is recorded in the veins of the pampiniformis plexus, first of all in the CFM or PD mode. And in case of positive results in CFM, a sharp increase in the diameter of veins or staining of the veins during the Valsalva maneuver, which can be compared with turning on the light in the room phenomenon. And secondary, by using a spectral pulsed wave Doppler in order to determine the duration of the reflex. Here you can see the phenomenon of the turning on light in the room at Valsalva test. Supine position, standing position, and this is Valsalva test in CFM mode and in power Doppler mode. Here you can see the spectral Doppler mode results. Positive, negative. At Valsalva test, it's antegrade blood flow at the rest. Then on Valsalva short reflux, physiological reflux. Now we can see another example. The arrow is a beginning of Valsalva test, and after the beginning start the constant prolonged reflux, long reflux. Another negative result of Valsalva test. We can see slowing down the blood flow during Valsalva without reflux, and here, same result, negative. What else we can see after surgical treatment of varicocele in ultrasound? In my practice, the testis on the site of the surgery was often increasing in size, presumably as a result of decreasing of venous outflow tract. You can see it here. Normal sized testicle and enlarged testicle after surgery. As in many other cases, ultrasound of scrotum is also only an initial method of visual diagnostics, and to clarify the diagnosis, computed tomography or magnetic resonance imaging can be recommended, prescribed, but in my practice this happens very rare. Some thin loops. Here we can see a phenomenon of turning on the light in the room at Valsalva test, turning on, rest, and Valsalva, turning on light, standing position, color flow mode. Another example of this phenomenon, we can see rest and Valsalva. And this is an example of a condition after the surgery. We can see the testicle on site of surgery is enlarged and more rounded shape. Thank you, that's all.